Good morning, everyone. I'm Dr. Archana, Senior Resident from Department of Ophthalmology, and our topic of discussion today is diabetic retinopathy. Diabetic retinopathy is the disease of retina caused by microangiopathy due to long-term effect of diabetes, leading to progressive damage of retina and resulting in blindness. This is the most common cause of severe bilateral visual loss in a working age group. As I told before, it is the most leading cause of blindness in the working age adults of between the age of 20 to 74. And at present, there are about 7.7 million people who are affected by diabetic retinopathy. And by 2050, the prevalence is estimated to be doubled. This is because of no, there is no early symptoms in case of diabetic retinopathy. Most of the patients present to us at the later stage or the severe stage. And both type 1 and type 2 diabetes are at risk. Early detection, timely intervention, and appropriate follow-up care can reduce the risk of severe vision loss by 95%. Coming to the pathogenesis of diabetic retinopathy, um, if we see, the most inciting factor is the hyperglycemia. It will initiate numerous pathways, which includes polyol pathway, advanced glycation end product pathway, renin-angiotensin pathway, protein kinase pathway, and also it will initiate inflammation. These all pathways will lead to oxidative stress, which in turn results in activation of the cytokines, especially VEGF, vascular endothelial growth factor, tissue growth factor beta, interleukin 1A, interleukin 6. And this cytokines will lead to retinal vascular dysfunction in the form of retinal blood flow changes, parasite loss, basement membrane thickening, tight junction dysregulation, and leading in increased vascular permeability. This pericyte loss will lead to microaneurysm and hemorrhages and also capillary occlusion, which in turn result in hypoxia, ischemia, and resulting in diabetic neovascularization. Whereas the increase in vascular permeability will lead to exudation, edema, and resulting in diabetic macular edema. So the main cytokine that is involved in this pathogenesis of diabetic retinopathy is the VEGF. There are three types of VEGF: VEGF A, B, C. Risk factors include age at diagnosis of diabetes, earlier the onset, more the risk of diabetic retinopathy. And duration of diabetes, same, more the duration of diabetes increases the risk of diabetic retinopathy. And poor metabolic control, pregnancy, hypertension, nephropathy, and other factors include smoking, obesity, hyperlipidemia, anemia. According to ETDRS classification, we can classify diabetic retinopathy into NPDR, which is non-proliferative diabetic retinopathy, and PDR, which is proliferative diabetic retinopathy. Non-proliferative diabetic retinopathy itself, it could be mild, moderate, severe based on the findings we see in the retina. In case of mild, there can be any few microaneurysms. And in case of moderate, along with the microaneurysm, there can be dot and blot hemorrhages and exudation. Exudation, it could be hard exudates or soft exudates. In case of severe retinopathy, all these findings like hemorrhages, exudates will be present in all four quadrants of the retina, and also along with that venous bleeding could be present, and also intraretinal microvascular abnormalities. Whereas in PDR, major finding is the new vessel formation or neovascularization. It could be seen in retina, and that could be pre-retinal hemorrhage or tractional RD. And as I told, the findings in the retina, it includes microaneurysms. We can see here dot-like, spin dot-like structures. These are saccular outpouching from the capillaries because of loss of pericyte. It can lead to dot and blot hemorrhages or flame-shaped hemorrhages. And soft X-rays are these cotton-like white structures in the retina, which is present in the nerve fiber layer, whereas hard X-rays are more crisp, yellowish, waxy lesions, which are present in the inner layer, inner plexiform or outer nuclear layer. In one more term called advanced diabetic eye disease, and it includes tractional retinal detachment. It is because of the severe neovascularization of the retina, which will lead to fibrosis and eventually result in tractional retinal detachment. And there could be pre-retinal hemorrhage. It is more of boat shaped, and this black arrow shows the site of bleeding. And also rubeosus iridis is nothing but the neovascularization of the iris. You can see the blood vessels in the iris, and these blood vessels are arborizing in pattern. It will initially develop in the pupillary margin and it will progress, and it can result in neovascular glaucoma. This slide shows a simulation of defective vision as experienced by a diabetic patient who is affected by the diabetic retinopathy. This is how a normal patient will see. And in case of diabetic retinopathy affected patient, they could see some black spots in their field of view, which we call it as scotoma because of macular edema. And when do we screen these patients? Based on recent guidelines by the AAO, that is American Academy of Ophthalmology, diabetic retinopathy preferred practice pattern for the recommended time of first retinal examination for patients with diabetes is, in case of type 1, the first retinal examination is 3 to 5 years after the diagnosis. Whereas in type 2, at the time of diagnosis itself, we have to do the first retinal examination. And in case of pregnancy, the first retinal examination soon after the conception. That is in case of overt diabetes, and yearly in the first trimester of pregnancy. The gestational diabetes will rarely causes retinopathy changes. And all these patients, after the initial examination, they have to be followed up every yearly. That is, annual follow-up is necessary for all the patients. And the screening, after the screening, how do we follow up the patients? So no diabetic retinopathy or mild NPDR, it is annual review. In case of moderate NPDR, every 6 monthly the patient has to be reviewed, and severe NPDR every 4 months, very severe NPDR every 2 to 3 months, and in case of PDR, every monthly the patient has to come for the review. How do we screen? There are various methods we can use to screen diabetic retinopathy. This depends on the resource setting. What are the instruments we have at our institute? It based on it could include dilated fundus examination performed by an ophthalmologist is considered the gold standard method for diagnosing diabetic retinopathy and monitoring patients at risk of developing diabetic retinopathy. One method it could include direct or indirect ophthalmoscopy or slit lamp biomicroscope examination of the retina, or it could also include retinal photography, including any of the following. It could be a 30-degree to wide field imaging, monophotography or stereo photography, or it could be a dilated or undilated photography. Any kind of fundus photography will be helpful to screen the patient. So the left side image, it shows how we do indirect ophthalmoscopy, whereas this one shows the direct ophthalmoscopy. And with the help of the slit lamp biomicroscope and 90D lens, we can visualize the retina. And this one is a fundus camera, which we can use to capture the image of the retina in dilated or undilated patient. So fundus photograph, it could be a conventional 50-degree. In case of 50-degree, we could see a optic disc along with that macula or posterior pole we can visualize. Whereas wide field imaging, it gives a view of 120 to 150 degrees. That is, along with the posterior pole, we could see the retina till the equator. And ultra wide field imaging, it is up to 200 degrees. That is, till the periphery of the retina can be visualized. And one more recent advance is the multicolor imaging. This usually we use red, green or red, blue, green colors to take the retinal imaging. Whereas recent days we can use multicolor imaging technology, which will enhance the lesions more precisely, and it will be helpful to identify even the finest lesions. In case of fundus fluorescent angiography, the site of it plays a very vital role in case of diabetic retinopathy. Every patient who's in the severe NPDR stage, to rule out any neovascularization, that is pre-proliferative stage, we can advise the patient for fundus fluorescent angiography. It will give a idea of whether the neovascularization is present or not. And also, if the we are planning to take the patient for focal laser to know the site of leakage, we can advise fundus fluorescent angiography and capillary non-perfusion areas. That's the extent of capillary non-perfusion area in the periphery or the posterior pole. FFA will be useful. And also foveal avascular zone. So foveal avascular zone is very important when it comes to the visual prognosis. Normally, the fovea will be avascular, but the diameter will be from 350 to 500 microns. In case of diabetic retinopathy, this area tends to increase. When this area increases, patient can have poor visual acuity even in spite of normal findings in the fundus photo or OCT. And in this image, you could see multiple pinpoint leaks. This is the foveal avascular area, and you could see some disc leakage. And this profuse leakage will indicate the site of neovascularization. And OCT is also called an optical coherence tomography. It is like taking a cross section of our retina. So it is specifically done using a machine. It could be a time domain OCT or a spectral domain OCT. So this is how our normal retina will appear in a OCT. It will display the all 10 layers of the retina. So the findings that we can see in diabetic retinopathy include hard exudates. It will have a post acoustic shadowing. And in case of hyperreflective foci, it will be a small hyperreflective dots and it doesn't have a post acoustic shadowing. And we can also see intraretinal cystoid spaces. Here, multiple cystoid spaces are seen, and it will be in the layer of optoplexiform and inner nuclear layer. And neurosensory detachment, that is the separation of the neurosensory retina from the RPE, we can see. And these findings are related with the diabetic macular edema, and it can resolve with the appropriate treatment. Whereas disruption of ellipsoid zone, external limiting membrane, and drill is disruption of retinal inner layers. These findings are structural loss to the retina. Even if we treat the macular edema, these things are not going to change and it will affect the visual acuity of the patient. So presence of this at the first visit itself, you can counsel the patient that the visual acuity is not going to improve even after appropriate treatment. And the one more finding is the epiretinal membrane, which can be seen after any inflammatory disease of the eye. It will be a hyperreflective membrane over the ILM, internal limiting membrane, and it will also interfere with the visual acuity. One more recent technology is the OCT angiography or OCTA. The idea of OCTA is to use particle motion within the vessels as intrinsic contrast. That is the moving blood cells. We use it as an intrinsic contrast. For this angiography, we don't use any dye. It is a non-invasive procedure. It can display the capillary beds at distant depths, separating the superficial and deep capillary plexus as well as choriocapillaries layer, and which has increased our understanding of the microvascular changes in the diabetic retinopathy. As I told earlier, foveal avascular zone is very important when we are talking about the visual prognosis of the patient. So normally you can see it is around 350 microns in a healthy individual. In diabetes mellitus itself, it tends to increase a little bit, whereas it keeps on progressing in NPDR and PDR. If it is increased beyond a limit, then the patient will have poor visual acuity and it is not going to recover. And there is a term called teleretina. It has been proposed as a cost-effective alternative to examination by an ophthalmologist, whereby retinal images taken at one site are transmitted to and interrupted at another site. This retinal photography, in addition to a visual acuity test with refraction, can satisfy the recommended screening criteria. And the digital retinal imaging takes appropriately only 15 to 20 minutes, and these images can be analyzed remotely by a grader to identify the presence of any referable or vision-threatening disease in the photograph. When compared with dilated ophthalmoscopic examination or the gold standard 7-field stereoscopic fundus photographs, the non-mediatic digital photograph have historically demonstrated good sensitivity and specificity for detecting diabetic retinopathy. It is mostly used in case of rural population where the patients do not have accessibility to the fundus camera. So we can go to those sites, we can take a digital photograph, refer it to an ophthalmologist who can grade these photographs, whether the patient is having a diabetic retinopathy, it has to be treated immediately, or there is a vision threatening disease. So, recent studies have indicated that the photograph screening programs are cost effective for population with over 3,500 individuals aged 50 to 80 years. You can see here it is a portable device. It is very handheld. It is very easy to perform. Now, minimal training is enough to perform this, and it will be attached to a smartphone. Even undilated photograph we can take with this camera. It will give a conventional 50-degree photograph, and we upload it in a software, and we will refer it to a ophthalmologist, and they will give a report, diabetic retinopathy screening report, and it will give a letter to the patient about the status of his retina. And the role of artificial intelligence in diabetic retinopathy has grown very immensely. And standardizing a constant method to analyze retinal photographs are of great interest, and early artificial intelligence methods seem to hold promise. These technologies solutions reduce the need for trained graders in the primary care setting and enable more efficient screening. AI reduces the burden of manual review of fundus photograph using technology to automatically screen fundus images for the presence of disease. A systemic review of this performance in diabetic screening has demonstrated that it has a very high sensitivity. It is 87 to 95.2%, but generally a low specificity, that is 49.6 to 68.8%. In case of teleretina, we refer it to the ophthalmologist. So, ophthalmologist, we have inter-observer variation. To overcome that, we incorporate the artificial intelligence into this teleretina. This images are incorporated into a mission that is having artificial intelligence, and the mission will read whether this patient is having the disease or not, and it will be verified in the end by the ophthalmologist. So you can see here that this image, these are the fundus photograph of the patients, and below is the how the mission with the AI reads the image. So this is a patient with fundus photo with no diabetic retinopathy. Okay. So the image in the AI based mission also is looking normal. Whereas in mild NPDR, you could see it shows in a color coding pattern. A red means alert, like a there is some disease going on in the retina. So it grades the color coded photograph into mild, moderate, severe, or PDR. So it is based on the deep learning system, and it will give a input like whether it is a referable or a non-referable. And non-referable means we have to rescreen in the 1 year. Whereas referable, we manual grading by the secondary graders, that is ophthalmologist has to recheck the report and then refer to the eye center. So this is how the report will be, and in the end it will give a positive it will give a report whether it is a disease retina or a non-disease. So in this you can see a positive result for vision threatening diabetic retinopathy indicates a high risk for severe non-proliferative DR, proliferative DR, or it could be a clinically significant diabetic macular edema. So this patient should go to the eye clinic or a tertiary eye care center where they are more precisely examined, or even OCT can or FFA can be taken for those patients. So how do we manage these? How do we manage diabetic retinopathy? So first is the general management. Systemic control of diabetes is the mainstay of treatment. So even if we give lot of treatment to the eye and the patient diabetes is not controlled, the diabetic retinopathy is not going to come down. So systemic control of diabetes should be insisted to the patient. And also we have to control the coexisting comorbidities. That is hypertension, hyperlipidemia, hypercholesterolemia, nephropathy, and other diseases are of paramount importance. In case, how do we treat diabetic macular edema? So diabetic macular edema causes vision loss. So we have to intervene in case of diabetic macular edema. That too, when it is center involving, that is the fovea. Even if it is a non-center involving diabetic macular edema, we can wait. So treatment of macular edema usually is needed in order to prevent loss of vision or to try to improve the vision. So in this treatment, it could be use of lasers or injection of drugs. That is the intravitreal injection of anti-VEGF or steroids. These will help to reduce the retinal swelling or the macular edema. So lasers, we can use focal grid laser or pan-retinal photocoagulation. Focal laser we can use for non-center involving macular edema, where the site of leakage it is away from the fovea, and it can be dealt with the laser, and it can be easily seen in FFA. After doing FFA, identify the site of leak and do a focal laser around the site of leak alone, not the whole retina. So intravitreal injection, it is given with the 1 ml syringe through the pars plana route into the vitreous cavity. It will be of 0.05 ml. Whereas retinal laser, we can do it with the slit lamp or indirect ophthalmoscopy using a contact lens. Here you can see, using a contact lens, we visualize the retina and we do the laser. The main role of this laser is to burn the retina. The main stimulus for this production of VEGF is the hypoxia in the retina. So we burn the retina and make it anoxic. So it doesn't increase the drive of VEGF. So intravitreal injection that are available or anti-VEGF, it includes bevacizumab. It is a off-label use only. It is not a FDA-approved drug. And later, the first FDA-approved drug is the ranibizumab, aflibercept, brolucizumab, and then the newly FDA-approved drug includes faricimab. And biosimilars also come into market. And these Razumab, Rani, Zosiva, these are all biosimilar of ranibizumab. So it is most cost effective than the innovator molecule. Each drug is ranibizumab is a monoclonal antibody. So similarly, each drug is a different structures and has a different dosage. The ranibizumab is given every monthly for the patient, aflibercept every 2 monthly for the patient, and brolucizumab we can give every 3 monthly. And this drug even every 4 to 6 monthly we can give faricimab. So after these frequency is followed up after three loading doses given every monthly. And in case of steroid, we have triamcinolone acetate and dexamethasone implant. The dexamethasone in this photograph, you can see one white implant. This is the dexamethasone implant, 0.77 mg. And it will have a effect in the retina for 3 to 6 months. It can be repeated after 3 to 6 months. Usually, it has a side effect of cataract formation. So it is mostly preferred in the pseudophakic eyes. The first drug that we use is the anti-VEGF. Eventually, if it is not resolving with anti-VEGF, there is a refractive macular edema, we can give a trial of steroid, or even we can give a combination of anti-VEGF and steroid at the same sitting. So laser, as I told before, there could be a focal laser, grid laser, or we can do a pan-retinal photocoagulation in case of proliferative diabetic retinopathy, where we give laser in the all 4 quadrants and leaving the posterior pole, which is essential for the vision. So this lasers we can use either organ laser or the frequency double LDR laser to deliver it. So advances in laser, it include Pascal. Pascal is pattern scanning laser. It is an integrated semi-automatic pattern scanning laser photoglycation system, and it can deliver up to 56 spots in one shot. That is, here it could deliver a 56 spots in a one shot, and constantly it will scan the retina of the patient. And micropulse laser, this laser emission allows for effective subthreshold tissue sparing laser treatment without any visible burns to the RPE. There will be a lack of chorioretinal scarring, which allows for both overlapping application of the laser and frequent retreatment of the same retinal area without causing noticeable retinal scarring. And limitation, it is like it will be like a under treatment. It will not resolve the disease. It will stimulate the RPE. It will make the RPE to absorb more fluid in the retina by reducing, but it is not as effective as the other laser. And since it does not cause any burns, we can repeat the laser in the same area again after 3 to 6 months. And one more thing is called Navilas, Navigated Laser System. It is a new prototype of retinal eye tracking laser delivery system with integrated digital fundus imaging, and it will have a live color fundus photograph, red-free and infrared imaging, and fluorescent angiography. These images are incorporated into that mission. Could have potentially increased the effectiveness and efficacy of a focal laser therapy for diabetic macular edema by aligning pre-planned treatment maps with real-time fundus images. So here you can see it will mark the area where it want to deliver the laser. So it also tracks the patient's eye. If the patient's eye moves, the machine will not deliver the laser because we are going near the fovea, which is essential for vision. If we hit fovea, patient is not going to have a good vision. So it avoids that problem, whereas it is not available with the other conventional lasers. So it will deliver the lasers only in the site that is pre-planned. And in case of proliferative diabetic retinopathy, a primary treatment option for PDR is laser photocoagulation of the peripheral retina, known as pan-retinal photocoagulation. And as we discussed previously, and this laser is used to obliterate some of the ischemic peripheral retina in order to decrease the VEGF release and induce regression of neovascularization. If successful, vitreous hemorrhage and fractional retinal detachment may be averted. And diabetic retinal patient with PDR, if at the first visit, if you identify the patient is having PDR, try to give laser at the same sitting itself. Patient in our situation, they have a poor compliance, and they tend to lose the follow-up. So you advise pan-retinal photocoagulation at the first visit itself and plan the treatment accordingly. And in some cases, anti-VEGF injection can also be used to induce regression of neovascularization, and anti-VEGF injection are also sometimes given prior to vitrectomy surgery in selected cases to lower the risk of intraoperative hemorrhage. So if we are planning to take up the patient for vitrectomy, pars plana vitrectomy, the risk of bleeding during the surgery is very high, since this neovascular vessels are very friable and they will bleed with any pressure changes. So before surgery, we give anti-VEGF injection like 3 days to 1 week prior to the surgery. And so it will take care of the neovascular part. So during surgery, the risk of bleeding will be very less. So surgical management, we do pars plana vitrectomy. It is used to remove the blood or any scar tissue from the retinal surface. And during surgery also, we can do laser, pan-retinal photoablation through the endo laser probe. work. And intraoperatively, we can inject any intraocular gas or silicone oil that may be needed to maintain the reattachment of the retina to the underlying layer and eyeball. So mainly pars plana vitrectomy we prefer in case of vitreous hemorrhage, fractional RT. So vitreous hemorrhage, we try to remove the blood in the vitreous and the underlying retina will examine, and if needed, we will laser the all four quadrants of the retina. And in case of fractional RD, we have to remove the all fibrous tissue. We have to reattach the retina. For after reattachment, we have to laser any site of break or hole, and we have to inject intraocular gas or silicone oil. In case of silicone oil, it has to be removed after 3 to 6 months. Thank you.